All right, hello everyone, and welcome to this session. I have a few words to say to open the session. I am Laurel Sprague. I'm the Executive Director of the Global Network of People Living with HIV, and I am myself a woman who's been living with HIV for more than 25 years, and it is a particular delight, thank you, it is a particular delight to be able to moderate this session. For those who, with me and even longer than me, have been fighting to have attention to women living with HIV and our health needs that go beyond our childbearing and our relationship with men, and really move into taking a look at women and our health, women with HIV and our health, in ways that respect our right to the highest attainable standard of health as human beings. I think this session is particularly interesting, and I am delighted to be up here with four panelists who are all working to take women and women's health very seriously as the human beings and rights bearers that we are. And so as far as I know, this is the first session that we've had that really looks at the health and well-being of women living with HIV across the lifespan. And I'm really delighted to be able to be part of this and to bring these speakers and their presentations to you. Before we go into the panel itself, I want to take a moment for all of us to come together to remember, commemorate, and also rejoice that a woman who was Prudence Mabelli lived and walked and worked and loved among us. So we would like to dedicate this session to Prudence Mabelli, who was a pioneering South African HIV activist who passed away earlier this month. Her intuitive activism was fueled by pain and by passion. As the first Black woman to publicly reveal her HIV-positive status in South Africa in 1992, Prudence was a trailblazer. Time and again, she was toying and marching and laughing for all of our rights. Her dedication to the issues facing women, especially to those living with HIV, is legendary. She never stopped working with and believing in support groups, even when donor funding said they were no longer fashionable. As founder of the Positive Women's Network, Prudence knew firsthand the power of communities, the concept of Ubuntu. Her fight for social justice was part of her DNA. When lesbians and gay men were killed in her home country, Prudence was in the front. When South Africa was in denial about its HIV situation, Prudence was there. When another HIV-positive woman died, Prudence could be counted on. As a founding member of the Treatment Action Campaign, she demonstrated her commitment to fighting for the underdog. Her innate conviction that role models are developed by doing rather than saying is perhaps the legacy she leaves with us. For Prudence believed in living the example she hoped others would emulate. The thousands of HIV-positive people, young and old, gay and straight, women and men, which we have done. Her belief in a brighter tomorrow, even when all around her things may have been falling apart, has ensured that life is easier today for all of us people living with HIV. When discrimination needed to be challenged, when rights had to be fought for, when the truth had to be told, Prudence proved a tireless defender of human rights. The HIV movement, without a doubt, shines less brightly today without Prudence playing her part. However, we are all stronger because of her. Prudence, the global HIV community salutes you. Thank you. So now, in Prudence's honor, it is my distinct pleasure to move to the first presentation in our panel today. Dr. Kochika Manyana from South Africa is a senior specialist and lecturer in the Department of Obstetrics and Gynecology at Charlotte Maseki Johannesburg Academic Hospital and the University of the Witwatersrand. Her main areas of work are in reducing HIV-related morbidity, maternal morbidity and mortality, and prevention of vertical transmission of HIV. And Kochika, if I could invite you to please come and share your presentation with us.
So thank you very much for the introduction and also the invitation to present at this session. So I think a lot of the time when we talk about pregnancy and living with HIV, we talk about PMTCT. And we have heard throughout this conference about some of the major successes we've had in PMTCT. The UNAIDS report from 2016 shows that between 2009 and 2015, 60% reduction in new pediatric HIV infections in the 21 priority countries in sub-Saharan Africa. And South Africa is one of the countries that has had immense successes with more than an 80% decrease in MTCT rates at early infant diagnosis. And it is with all these successes that it's been hailed as one of the great public health achievements of recent times. And then just sharing some of the data from our own program in Johannesburg, South Africa, we see that as the programs evolved and we had more efficacious ART interventions and more HIV-infected women started on treatment, our MTCT rate has decreased dramatically to less than 1%. We currently have option B+ in the country. But for this presentation, I want to say that it is more than just about PMTCT. So what I'll focus on for the next few minutes is talk about maternal health, and specifically talk about pregnancy and HIV disease progression, then talk about maternal mortality, which is one of my areas of interest, and then lastly talk about the known and the unknown about obstetric complications in women living with HIV. So if we're looking at disease progression, I've selected two papers deliberately because we're going to have more women who are HIV infected falling pregnant already on treatment. So the first paper is looking at incident pregnancy and time to death or disease progression in HIV positive women started on ART. And the study was done in South Africa from 2004 to 2011. And it was a large study with over 7,000 ART-naive women who were followed up for a median of 14 months. And the outcomes were looking at disease progression, death, and loss to follow-up. And what they found was that in women who had an incident pregnancy after being started on treatment, the rate of death was lower than in women who did not become pregnant. And then at the time of the incident pregnancy, the median time on treatment was 14 months, and the majority was virally suppressed, and they also had CD4 counts more than 200. What they also found was that younger women, those between 18 and 25, were more likely to fall pregnant, and also women with advanced HIV disease were likely to fall pregnant. And then in terms of disease progression, there was also no association between an incident pregnancy and disease progression. So the conclusion from the authors was that incident pregnancy is not associated with increased risk of disease progression or death in women already on treatment. What they also found was that in women who became pregnant, there was a decreased risk of loss to follow-up. So a lot of people talk about this healthy pregnant women effect, where obviously women who are younger are more fertile, more likely to fall pregnant, and also women without advanced HIV disease are likely to fall pregnant. So the second paper published this year in JADES looked at the effect of pregnancy on response to treatment. And the aim of the study was to explore the effect of incident pregnancy in women started on treatment. And they specifically looked at virologic, immunologic, and clinical response to ART. Again, this is important as more women are going to fall pregnant already on treatment, whether started outside of pregnancy or in pregnancy. And the main reason this is important also is because pregnancy is associated with both biological changes and behavioral changes as well. So here, the data is from 3 prospective studies that were done in HIV-discordant couples, and over 60% of the HIV-infected partner was female in the study. And the data from 7 countries, studies were done between 2004 and 2012. So overall, they had just over 1,000 women, and 110 of them fell pregnant after being started on treatment. And in this study, they found that being pregnant after starting treatment was not associated with time to viral suppression, virologic failure, or disease progression compared to women who did not become pregnant. They did find an associated mean decrease in CD4 count, but we do know that with the physiological hemodilution of pregnancy, there is a hemodilutional effect, which also affects your hemoglobin, which is why you get a hemodilutional anemia. So what these two studies are showing us is that in women who already started on treatment, incident pregnancy doesn't affect response to treatment, doesn't affect disease progression, and it doesn't affect mortality either. So now just turning to maternal mortality, there's this publication from UNAIDS from this year titled "With Women Lead, Change Happens, and Women Advancing an End to AIDS." Unfortunately, HIV is still the leading cause of death in women between the ages of 30 and 49. And it's also the leading cause of death, the third leading cause of death in women aged 15 to 29. And this encompasses the reproductive age group of women of 18 to 45. And then if we're talking about maternal mortality in the era of ART, it has been shown that there is a survival benefit of starting treatment, even in women without advanced immune suppression. And I've just shown a few references there just to support those statements. And obviously with option B+, the experience is still limited, but there is a suggestion of a decline in maternal mortality in women that are started on treatment within option B+ programs compared to women started outside of these programs. But the numbers are still small, as I said, because the programs are still in their early stages. Interesting publication from South Africa published last year also shows that there's a 50% decline in odds of death from TB with expansion of the country's ART program. And we know that TB is one of the leading causes of maternal mortality as part of your non-pregnancy related infections. And then just sharing data from one of our studies as well, we looked at maternal deaths in a very large tertiary hospital in Johannesburg, and we looked at deaths over a 19-year period, and we had a total of 692 maternal deaths, just to say that this goes up to 6 weeks postpartum. And the majority of women who died were diagnosed as HIV infected during pregnancy, over 80% of them. And obviously there was advanced immune suppression with the median CD4 count of 136. And throughout the review period of 19 years, non-pregnancy related infections were the leading cause of maternal deaths. But we're starting to see a change as our ART program has matured, and we've put more people on treatment. The proportion of non-pregnancy related infections that are causing maternal mortality is decreasing. And although the majority of women who died in our study were still pregnant at the time of admission, the majority of deaths occurred postpartum. But in most cases, the condition that causes the deaths occurred either antenatally or intrapartum. And despite routine testing being part of our PMTCT program and part of our antenatal programs, there were still women who died without an unknown HIV status. And those women were unlikely to have access to antenatal care. They're also likely to die within 24 hours of admission and also die at an early gestational age, meaning that some of them were undelivered at the time of death. And now just looking at obstetric complications and maternal deaths, and it's one of the things we forget to think about. As I said, the preoccupation, rightfully so, has been about PMTCT. But similar to women without HIV, puerperal sepsis, complications of hypertensive disorders, and obstetric hemorrhage are the leading causes of maternal mortality, the direct causes of maternal mortality in women living with HIV. And there have been a lot of debates on whether there's an increased risk of these complications in women living with HIV. The only consensus has been on puerperal sepsis. And the highest risk has been consistently shown to be associated with non-elective cesarean sections. And a paper published in 2014 and another one published in 2016 shows that even in women without advanced disease, even with availability of ART, pupil sepsis risk is still higher in women living with HIV compared to women without HIV infection. And obviously there's issues about altered immunity, even when there's immune reconstitution associated with ART use. And then looking at hypertensive disorders of pregnancy, they have a complex pathology which is not understood, but it is thought that one of the underlying pathophysiological causes of hypertensive disorders of pregnancy is that it has an immunological basis. For a woman to be able to continue with her pregnancy, she has to develop immune tolerance to the fetus, which has paternally derived antigens. And it's thought that in cases where the woman develops preeclampsia, there's a loss of this immune tolerance. And the debate about hypertensive disorders of pregnancy has been around the modifying effects of ART, obviously on the maternal immunity, versus the inflammatory changes associated with HIV. Because also with the pathophysiology of preeclampsia, you get endothelial damage, which causes the hypertension, then inflammatory causes of HIV also causing vascular damage. And the available data on hypertensive disorder is currently inconsistent. And one of the things that complicates it is that populations that are involved in the studies are quite different in terms of their risk factor for preeclampsia, timing of diagnosis of disease, and also the treatment that was used. And then just looking lastly at obstetric hemorrhage, also the data there are inconsistent. And it's also related to the definition of postpartum hemorrhage that is used in the studies that is not standardized. But one study that was done in South Africa with over 15,000 peripartum women showed that women with HIV are more likely to receive blood and blood products. And just about a half of these women had CD4 counts less than 350, and 81% of them were on ART. And this is also complex because women with HIV are likely to have underlying anemia related to the pregnancy, nutritional deficiencies, and to HIV itself. But the study showed that the reflex to give blood and blood products was more with women with HIV than without. So I know I've covered a lot of topics, but what I've tried to show you is that it is more than just about PMTCT if we're talking about pregnancy and women living with HIV. And we need to shift the focus now from PMTCT and talk about maternal health. And maternal mortality, unfortunately, is still a concern. As I showed, women of reproductive age, HIV is still the leading cause of death. There are reassuring data on disease progression and response to treatment in women who are falling pregnant already on treatment. And one of the important things that we also forget to talk about is that access to antenatal care, all the basic obstetric issues, still remain critical in women living with HIV.
Thank you very much, Dr. Mignani. This was very important information and so useful to have. I know people in the audience like myself, we were all just trying to soak it up, and I'm sure you'll have many questions. The next presentation comes from Dr. Sinead Delaney Morletwa from South Africa also from the University of Witwatersrand, as well as other work. She is a clinical epidemiologist with more than 15 years experience working in sexual and reproductive health and HIV prevention. Please, go ahead. Thank you.
Good morning, everyone, and thanks very much to the organizers for asking me to talk to you about this important topic. As I was thinking about the session, I also received the news about first of all, here are my conflicts of interest. I received the news of Prudence Mabele's death, and it caused me to reflect on a story that she told at one of the many meetings we have in South Africa about how to prevent HIV infection in young women. And she reflected on her story of growing up a good girl in a good family, doing well at school, and then she had an opportunity to go to university, and at university she was a good girl and she worked hard at school, And then she said she thought, but hang on, I'm now an adult. I've done everything that people have told me about being a good girl, but kind of now I'm grown up and I need to do grown-up things. And one of those grown-up things was having sex with a man who had HIV, and she became HIV infected. And her story was really important, I think, to reminding us about how some of the choices that young women make really lead to consequences that are not necessarily sort of within their considerations. And at Prudence's funeral, Mark Haywood made a pledge that in Prudence's memory, we would ensure that all young women have access to ways of protecting themselves against HIV, and he included PrEP in that list. So I want to talk to you a little bit about PrEP, but in fact I'm going to talk to you a lot about what else we need to do for young women's health. So just to remind you, and probably if you're in the room you don't need reminding, but about 2/3 of new HIV infections occur in adolescent girls. And the majority of them occur in sub-Saharan Africa, and particularly in Eastern and Southern Africa, where about 1/4 of new infections occur, but only 10% of the world's adolescent population live. Amongst young people living with HIV, there are an estimated 2.1 million young people, and again, 8 out of 10 of them live in sub-Saharan Africa. What we know is that girls are up to 8 times more likely to be infected with HIV than their same-age male counterparts. And what we've also learned in recent years is that unlike many other age groups which have benefited from the expansion of access to antiretrovirals, adolescents are the only ones that have not benefited, and in fact, AIDS continues to be the leading cause of death in sub-Saharan Africa. And why has the world started to pay more attention to adolescents? These have been a traditionally neglected group, and in part that's because young people are generally healthy people and don't access services. But as you can see from this map, looking at the total population aged 10 to 24 in 2013, already a huge proportion of the population in sub-Saharan Africa is under the age of 24, and that number is expected to be even greater by 2050, with about half the population expected to be under the age of 24, and the largest group of adolescents in any region in the world. And this is a population that then, in absolute numbers, is susceptible to HIV infection, and all the efforts that we have invested to date, we are going to have to triple if we're really going to prevent HIV infection in this population. But HIV is not the only health problem facing adolescents and young women today. In 2016, The Lancet prepared a commission on adolescent health, and included in that were some assessments of the adolescent global burden of disease. What they did was take the 236 causes of disability-adjusted life years and essentially group countries according to their ranking into 3 categories. And these categories really reflect what is called an epidemiologic transition. The epidemiologic transition follows the demographic transition, where we see with improvements in economic development that mortality declines and birth rates decline, and many countries that are in high-income countries experience their demographic transition sometime around the Industrial Revolution. But in sub-Saharan Africa, we're seeing increasingly countries going through this demographic transition. And what we see is a transition then from diseases of poverty to non-communicable diseases. So under the diseases of poverty, these are countries that largely have a huge burden of infectious and vaccine-preventable diseases, challenges associated with malnutrition, so either undernutrition or poor nutrition, and then diseases associated with poor or health outcomes that are associated with poor sexual and reproductive health. There are a group of countries which have transitioned out of the disease of poverty. They are really their main cause of death or burden of disease are injuries. And then there are countries where the main burden of disease are non-communicable diseases, physical disorders, mental disorders, and substance use. And when we look at this global adolescent health profile, what we can see is that 51% of the countries that have a multi-burden disease, or rather 51% of the population of adolescents in the world live in countries that have multi-burden disease. And about 2/3 of the DALYs that are associated with multi-burden disease come from countries in sub-Saharan Africa. So many of you might think, well, this is a big problem, what are we going to do about it? But I would argue that it's also a huge opportunity. And it's a huge opportunity because of the population that we're dealing with. While adolescence is a period of intense physical, neurocognitive, and social transition, and young people are going through puberty as a result that stimulates changes in development of the brain, and many of these changes are also associated with life transitions, leaving school, getting new jobs, getting married, buying a house. It's this interaction between the physical development and the social environment that really shapes the capabilities of that individual, both in terms of their health in the current moment, but also really has a strong influence on what happens to their health going into the future. And we talk now about the triple dividend because of the impact it may have, in fact, on the children that these people have. So investments in adolescent health and well-being bring a triple dividend of benefits now into future adult life and into the next generation. So when we think about what's driving poor health amongst adolescents, the Commission highlights tobacco use, alcohol use, poor nutrition, so overweight and obesity, and unprotected sex or unsafe sexual activity as key drivers of much of the burden of disease globally, and even more so in multi-burden disease countries. And what's important in terms of our programming is that we need to move away from a focus on health problems to address those underlying health risks that emerge, particularly during adolescence, when people are experimenting in a developmentally appropriate way, but we need to reduce the harms associated with those experiments, as well as to address the broader social determinants of health which shape the context in which those adolescents live. So now I want to talk about Bongi. She is a young woman who attends a clinic in downtown Johannesburg, and she came to us looking for HIV prevention because she said she lived in a rough neighborhood and was scared of being raped and getting HIV. She has a steady partner that she's been with for 6 years, and she says that he's her best friend and she tells him everything. But when you talk more to her, it turns out that he has been known to physically assault her, and he also has other partners. But Bongi lives, she doesn't live with her partner, she lives with 3 roommates, and together they talk about everything and share everything, and they say that they enjoy fun and they like to party a lot, and some of those parties they end up sleeping with other people. And so Bongi has another partner that she's met because he's smart and sophisticated, and she now sleeps with both of them, and condoms are difficult for her to use. So this is not an unusual story in our clinic. This is data from a survey that was done in 500 adolescents aged 15 to 19 as part of a larger study that was looking at the determinants of health in young people in disadvantaged environments. And what you can see is that young women like Bongi have high chances of being sexually active, but falling pregnant as a result of those activities. They also experience high levels of violence, are prone to substance use, and often experience poor mental health. So why is it that young people like Bongi are not necessarily seeking help for those problems? Well, there are a number of barriers in access to healthcare, and in many countries, one of the barriers in access to healthcare are the legal constraints around providing services for people under the age of 18. Healthcare providers are also an important barrier, and the attitudes of healthcare providers really influence whether young people are able to seek care. But adolescents also, because of their developmental stage, are acutely sensitive to judgment and are anxious about kind of the changes that are occurring in their lives and in their bodies, and may also be very sensitive to perceptions of judgment by healthcare providers. They're also less experienced with healthcare, so it actually takes longer to talk to them about some of the issues. They are learning many things that many of us take for granted. But importantly, an asset are peers. Peers are an important source of information and often share experience with each other, and that can certainly be leveraged to advantage for healthcare services. And importantly, there are other gatekeepers in young people's lives, family, partners, and other people who may influence young people's decisions about what is safe and what is not safe. And they also need to be engaged in healthcare provision for young people. So what are some of the actions that can be taken to address some of these barriers? And what I want to do is share with you the experience that we've had of setting up services in the inner city of Johannesburg for young people, and the actions that we took to address some of these barriers. So the first thing is that it's in resource-constrained settings, it's useful to prioritize services where there are youth champions, where there are people who are going to drive this agenda. Youth are incredibly important in the development of services. They're the ones who can tell you, you know, I'm not going to walk through this door because there's no sign that tells me it's okay on the other side to go through this door. And they're the ones who also, the first person they talk to will be the security guard and identify that we need to train the security guard in youth-friendly services. We also trained healthcare providers, and we did this actually doing formal assessments of youth-friendly services that are based on the WHO guidance around youth-friendly services, and we developed action plans for the clinic and for surrounding clinics to improve their services for young people. We identified the importance for this age group of referral services, particularly for social, educational, and mental health services. And we recognize the value of having data to prioritize what services to provide and to whom. And so invested a lot in routine data collection for a population which is not generally reflected in national health data sets. And then we focused very much on promoting comprehensive primary healthcare services and also leveraged social media to engage with young people. So this is the clinic in downtown Johannesburg. It offers a comprehensive health services, including HIV testing, treatment, has just started offering PrEP, also provides STI treatment and family planning, and care for common health conditions. Young people coming to the service, the prevalence of young people testing at the service is 10%, and this was one of our first reflections, is that the service was set up to provide treatment for HIV-positive adolescents, but in fact, we had 9 out of 10 opportunities to prevent HIV infection in these young people. And at the moment, the service sees over 1,000 young people a month. So I think what I wanted to share with you is the importance of promoting the comprehensive package of care. In April last year, we started to talk about status-neutral services and the need to develop cascades not just for treatment, but also for prevention, and to promote, whenever young people came for services, testing and sexual and reproductive health services for those that were positive. And since we started doing that, we've seen an uptake of services overall in terms of the number of people attending services, but also the diversity of services that they now access. And so when we go back to Bongi, she came to us looking for PrEP and looking for HIV prevention because she had had a few pregnancy scares, and she'd come to the clinic and she'd heard about PrEP, and she'd realized, now I could have an option that could decrease my worries. But things are not all perfect for Bongi. She still knows that her family don't know that she's taking PrEP, and they would be shocked to know that she was sexually active, let alone that she was preventing HIV. So there's still a lot more to be done. But importantly, as we go forward, when we think about HIV prevention or HIV care for young people, it's important that we begin to reconfigure our health services to move beyond sexual and reproductive health. Their needs are broader, and there are potential dividends that can be reaped through these broader investments. We need to begin to identify other health problems and focus on linkage to care for those. We need stronger implementation of preventive interventions for these pervasive risk factors like tobacco use and alcohol use and substance use. And importantly for this population, we need to move out of the health sector. Education is a key partner. Interventions in schools are going to be important in terms of providing information, but also potentially providing services on site. In countries, in low and middle income countries or multi-burden countries, we need to think about access to social protections. And importantly for this age group, we need to think about transitions into the workforce. There are huge research gaps or information gaps when it comes to designing some of these programs, and so we need to address these knowledge gaps so that we can move to scale. There are important developments, I think, in many parts of sub-Saharan Africa, and our own program in South Africa, She Conquers, is definitely trying to be comprehensive in its responses to HIV and other health issues for young women, but we can definitely do more. And throughout this, nothing for us without us. Youth involvement is key. So thank you very much.
Thank you so much, Sinead. It's lovely, isn't it, to have someone talk about adolescence and challenges in a positive way that sees them as opportunities and really is focused on what services look like and what needs look like from the perspective of adolescents and is focused on their meaningful engagement. So thank you very much for that. Now it is my pleasure to introduce to you Dr. Kepembwa from Zimbabwe. She is the National Coordinator for Cancer Prevention at the Ministry of Health in Zambia, amongst so many other things. And Sharon, I would invite you to take the stage and speak to us about your work with HPV. Thank you.
A very good morning to you all. My name is Dr. Sharon Kepembwa from the Ministry of Health in Zambia. Zimbabwe is one of our provinces. No conflicts of interest to declare this morning. Just to give a background, as I was thinking about the presentation that I have to do today, which basically talks about challenges and solutions, and thinking about how to place what we have in front of us, I thought the best way would probably to look at what we have done in our country, which will probably mirror most of the countries that are living with the issues of HPV and women living with HIV. What we do know is that invasive cancer of the cervix is one of the most common malignancies that we see worldwide, particularly in the developing world, which have over 80% of the new cancer cases in cervical cancer. When we look at the sub-Saharan region, we see that 22% of estimated new cancer cases in females are occurring in the sub-Saharan region. If we look at a country like Zambia, all the new cancer cases that we see in the adult population, cancer of the cervix accounts for more than 30%. And the next cancers that we see, like breast, will account for about 8%. So we're basically looking at the majority of the cancers that we're seeing in a country like Zambia, which will probably be the same that we're seeing in other countries, going to almost 40% of what the burden of the cancer cases. What we know from the various studies that have been done is that women living with HIV are at a much higher risk for incidence, progression, persistence of cancer causing the oncogenic type of HPV infection. They tend to present at a much younger age with cancer of the cervix. Some of the reasons given is that they have a more rapid progression of chronic persistent HPV infection. This could be that in this population there could be a relative immunosuppressive state even while on ART. Of course, one of the major drivers of them having cancer of the cervix is that in most of our countries we have limited to non-existent cervical cancer screening services. Like I said, to look at the challenges and the solutions that we have, we are going to look at the Zambian program, which as we go on, we'll probably look at the challenges we faced and are still facing and the solutions that we have come over with. Zambia, a country of 16 million people, life expectancy of about 60 years. 56% of these women live in rural areas. We have an adult HIV prevalence of 13.3%. Going back when we had a raging HIV epidemic in our country, with a physician-patient ratio of 0.12 per 1,000, we were beginning to see an increase in cases of cervical cancer in our hospitals, our clinics. You found that cervical cancer was one of the leading causes of admission in the gynecological ward, and we were beginning to see that the women were presenting at a much younger age. We did not have any chemoradiation treatment center. We were taken to South Africa, to Zimbabwe for women who had cancer of the cervix. At that time, most of the women would come in with HIV as well, and we would be able to, only those that the government could afford, could go for further treatment, to seek treatment in Zimbabwe or in South Africa. Of course, HPV vaccination was not there. With only 25 gynecologists in the country at the time, and knowing that most of these were actually based in the urban areas, was a challenge. 6 pathologists in the public sector and no cytologists. One of the huge things is having competing priorities. The country is dealing with the HIV, which is coming in, and you're also dealing with the other non-communicable diseases, malaria, which was still killing a lot of people. How could we prove that the women living with HIV had a higher risk of having cervical cancer or HPV infection? A study was done in 2004 in Zambia, in Lusaka. At that time, ART was only available, it was centralized, only available in the capital city. So the women who were coming to access ART treatment were invited for screening as well. And we enrolled 150 women. And these women, we found that just from screening them, just from the screening that was being done for these women, we found that 20% of these women had lesions which were 19% suggestive of cancer. And only 6% women from cytology analysis had normal. There was 17% with ASCAS and 23% with low-grade squamous cell intraepithelial lesions and high-grade for 34%. These results were shocking, but these results also gave us a platform to know that we could now lobby to have funding for the women who were living with HIV. And the CD4 count range was from 7 to about 242. What I have to emphasize today is that as we look at the various challenges and we try to see how are we going to capture these women to ensure that they come into a screening program, how do we set up these screening programs? We have to look at the local solutions. We looked at our local solution. Like I said, we had a cytology-based screening program which was limited and led by doctors. And we knew that the doctors were very few, and it was not going to help us to scale up this program. We looked at this method, and we looked at visual inspection with acetic acid. At the time, was what we needed to implement. It was more available, it was low cost, and we implemented the same visit, and optimally accurate, looking at the inadequate laboratory infrastructure that the country had. The next thing was to ensure that these women who came for these visits were also getting treated in the same visit, because splitting the visit had shown that we were going to have a higher rate of loss to follow-up. We started with cryotherapy, had challenges because first we have to import it from South Africa. Second, we have to also the logistics of getting the gas into the country is very expensive. We, with time, have started phasing out and using thermocoagulation as an alternative. But like I said, we have other countries in the African region who are still using cryotherapy because they might have plants that are working. Ensuring that the nurses and doctors were trained in VEA, cryotherapy, and LEAP. Looking at the few nurses that we have, the few doctors that we had, and visual inspection with acetic acid being very subjective, we looked at having point of entry electronic data which we could analyze. We came up with a distance consultation where the nurses from far areas could equally be able to consult the specialists in the capital city, and the consultants on that program are able to get a text whenever the nurses had a question that they needed to ask. One thing that you see is that we need continuing medical education. Sometimes it's not that the women come late to seek these services, but our health care workers do not understand what the program is about, and the women might find themselves being delayed in the process. The program implementation started in 2006, integrated into two government-operated health clinics. It was targeted HIV-infected women. It was nurse-led because we knew we had more nurses than we had the doctors. With time, we opened it up to the women who were HIV and infected or did not know their status. But what we also offer in that clinic is HIV testing. Because when we saw the women who came in and they did not know their status and referring them just down the corridor to go and get tested, most of them would turn and go back home and not know their status. It also, that they come in, also destigmatizes the program as well, and women feel much happier to do their HIV testing in the atmosphere that they have come for cervical cancer screening. We've done a three-phase national scale-up with government ownership, starting from the provincial centers, which have nursing schools, so that we have in-service training, and the nurses who are getting trained are also getting oriented in cervical cancer screening. We moved, so the first phase is completed. We are now at the phase 2 and 3, where we're also scaling up in the district hospitals and in the health facilities. That is how the screening program looked in 2006. The green is all that we had, and everywhere else, we had nothing. This is how we look. We still have a bit of red, but we have more green, and we need to go green by 2021, as our strategic plan stresses. Where you see blue is that Zambia has been one of the first countries to get funding from the Global Fund, and this year we're opening up 25 clinics from the resources from the Global Fund. What have been our achievements? Cervical cancer screening should be part of has been made part of the HIV treatment guidelines. HIV linkages in the National Cancer Control Strategic Plan. So the HIV care and the cancer control programs have to speak to each other to a great extent. Over 370,000 women have gotten screened. It might look like a lot, but we have millions out there that need to be screened. 29% HIV infected women. When we started the program, we were at 56% HIV infected women. We've reduced to 29%. So we need to strengthen these linkages again, because the women living with HIV need the screening much more. Because of this program, we have been able to do HPV vaccination demonstration. And next year, we're moving into a national scale-up for the whole country. The government has gone ahead to establish the chemoradiation center, which has inpatient facilities for over 200. And we've seen slowly the increase in the number of partners that are helping with screening the women who are living with HIV. Challenges still lie way before us as far as cervical cancer screening is concerned in the HIV population. We have limited funding. Even though we have PEPFAR, we find that cervical cancer is not a core of PEPFAR, so sometimes other activities are given priority. And we find that some other cancers, HIV-related cancers, are given more priority. Still, the women who come for screening, it's not mandatory, and I put mandatory in quotes, because it's not like if they don't come for screening, you won't give them treatment. But they need to be formalized, more effort, in ensuring that every woman who's accessing HIV treatment gets screened for cervical cancer. Because the gains we've made from HIV care and treatment are slowly reversed when the women come in with advanced disease and they succumb to cancer of the cervix. Integration must go on between cervical cancer screening and HIV. HPV vaccination for adolescent and screening is needed. For the program for HIV-infected women and adolescents, as soon as they become sexually active, they're eligible for screening. Those are the screening guidelines in the country. One of my recommendations today is that we have to make cervical cancer screening part of HIV care. We have to research, find strategies, because by WHO guidelines, The adolescents who receive vaccination, we have reduced to 2 doses. But for adolescents living with HIV, we are recommended that we give them 3 doses. So what are we putting in place to ensure that these adolescents are not stigmatized and yet they get the 3 doses? More funding and more funding has to be found for cervical cancer screening. Acknowledgement to the Ministry of Health of Zambia, who have supported the cervical cancer screening from the very beginning. The Center for Infectious Disease Research in Zambia, my employers, who have supported this program from the very beginning, and all the other cooperating partners that are working in cervical cancer screening in Zambia. Of course, it's the nurses and the doctors and all the support staff that work in these clinics. And to the International AIDS Society for letting there be a session where we're looking at women living with HIV. What else do they need apart from just giving them the drugs? And for the women of Zambia for advocating and accepting the program. Thank you.
Thank you very much, Sharon, and thank you for your sense of humor. I didn't even hear myself say Zimbabwe, but please give all credit to the Ministry of Zambia, Ministry of Health in Zambia, for that work. It was excellent to hear this combination of science and policy and implementation, and then your advocacy on behalf of women living with HIV, so thank you very much. And now it's my delight to introduce to you Dr. Cassetti, who is an infectious disease specialist and the medical director of Helios Salud, a clinic devoted to the care of people living with HIV in Buenos Aires. And she will speak to all of us about, let me start it, HIV and menopause, please.
Thank you, Laurel. Good morning. I would like to thank the organizers for inviting me to give this presentation. This is my disclosure. I will focus on women who age with HIV and reach menopause. This is the outline. I will begin with epidemiology, then definition, onset of menopause, few comorbidities and its approach, and finally antiretroviral treatment. According to UNAIDS report, there are 36.7 million people living with HIV worldwide. Out of the total number of adults, 51% are women, and of these, 14.7 are women over 50. In the last 10 years, this number has doubled and continue increasing. Related to the prevalence of women living with HIV, you can see here that the highest prevalence is sub-Saharan Africa, and in developed countries, the prevalence is lower, and in Latin America is 30%, and in the Caribbean region, 50%. The definition of menopause is the permanent cessation of menstruation for 12 consecutive months, without any obvious causes, such as surgery or chemotherapy. It results from the loss of ovarian follicular activity. And this definition doesn't require any lab confirmation. Irregular bleeding and ovulation and amenorrhea are common in HIV-infected women. With a study which is the largest cohort of HIV-infected women in US, demonstrated that over 50% of HIV-infected women with amenorrhea of at least 1 year had FSH levels in premenopause range, not in postmenopause range, not consistent with menopause. So these women may have prolonged amenorrhea rather than menopause. And why is this so important? Because this may have implication for contraception counseling. These women may get pregnant. Therefore, the traditional definition of menopause should be reviewed in this population. Anti-Mullerian hormone is a biomarker of ovarian reserve. However, it's not the common use in our clinical practice. For definition of menopause, is used FSH levels. Related to the age and onset of menopause, data on the association between HIV and earlier age and menopause is conflicting. There is studies in which we can find that definition of menopause is not homogeneous, the group of women is not comparable, among other factors. Women living with HIV are at higher risk of developing early and premature menopause. Early menopause is between 40 and 45 years. Premature menopause or premature ovarian failure is before 40 years. Both are associated with increased risk of diabetes, cardiovascular disease, and linked to alteration in mood, sexual function, and a decline in quality of life. It's important to begin the screening of these complications early. Moving on to depression, depressive symptoms is 2 to 4 times greater in HIV-infected individuals than in general population. Around 50% of HIV-infected women have characteristics consistent with depressive symptoms or depressive disorders. We can also say that women with depression present lower rates of adherence to antiretroviral treatment, and this may lead to treatment failure, increased rate of mortality, higher rates of STDs, and also decreased cognitive function. There is a particular risk associated with HIV-related stigma, loneliness, and domestic violence. And it would be convenient to start this screening, the screening of depression, as soon as menstrual irregularities begin, because depression can be present in the early menopause. As you know, the prevalence of osteopenia and osteoporosis in HIV population is high. These are the traditional risk factors related to the smoking. The HIV population smoke almost double than the general population. In the HIV-related factor, all antiretroviral scheme decrease bone mineral density, particularly tenofovir and its association with PIs. And as a secondary risk factor, the vitamin deficiency in this population is very frequent. And we can consider, or would be considered, HIV as a secondary risk factor. In this graph, you can see on the left that the bone loss is greater in premenopausal women living with HIV than in uninfected. On the right, the bone loss is greater in postmenopausal women with HIV compared to HIV uninfected. And besides this, the bone loss is higher in postmenopausal than premenopausal women living with HIV. Risk of fracture is increased in postmenopausal women. The proposed screening for bone disease, this is one of the guidelines, is a GIAS guideline, in which the DEXA scan is indicated in postmenopausal women, in men over 50, and in the rest. Measure of vitamin D is recommended in people with low bone mineral density and the other factors, or in all patients at presentation. First assessment estimated 10-year fracture risk. It is for people over 40, and we carry out with or without DEXA scan. Related to the cardiovascular disease, you can see here the traditional risk factors in HIV-infected population: smoking, hypertension, diabetes, dyslipidemia, ART different profile, lipid profile, immune activation and inflammation despite virological suppression. Besides this, in perimenopausal women, we can find high waist circumference, elevation of triglycerides, low HDL, and insulin resistance. Specifically, decreased estrogen levels produce a decrease in endothelial function, increase in inflammatory biomarkers, and increase in intima media thickness levels, among other mechanisms. All of these factors add a higher risk to develop cardiovascular disease. However, no study has focused specifically on the risk of cardiovascular disease in menopausal HIV-infected women to date. Related to the screening in menopausal women living with HIV, the pap smear is recommended yearly. This is a difference with women, menopausal women, uninfected, because in uninfected women, after 3 negative PAPs, we don't need to continue screening. Screen STDs repeat periodically if it indicated. For osteoporosis, we request the baseline DEXA scan for all menopausal women, and then annual. For cardiovascular risk screening, lipids initially and repeat periodically, assess cardiovascular risk in next 10 years. We can use 3 risk calculator, Framingham, DID, and ACC. The majority of physicians prefer ACC, but it's convenient to follow the patient with the same score and not to switch. For depression screening, we recommend, the guidelines recommend at baseline and annually. For breast cancer, this is the other difference with the uninfected women. For breast cancer, mammography yearly. For colon cancer, screening colonoscopy from the age of 50 and onwards. I would like to point out that the intensive screening in women living with HIV is proposed with pap smear, osteoporosis, and depression. This is the most important difference compared to uninfected women. Which are the interventions? Promote the smoking cessation, send the patient to the clinic or to see the specialist, reduce alcohol intake, encourage exercise regularly, start on statin according to the guidelines. Related to the vitamin D deficiency, we as infectious disease physicians give the replacement. However, the endocrinologists give the other interventions, bisphosphonates, calcium, etc. Adhere to antiretroviral treatment, and check the polypharmacy and drug-drug interaction, and also involve other health professionals. Working as a team is very crucial. Finally, antiretroviral treatment, there are 2 studies that included only women. This is the first time in the history of antiretroviral treatment that the clinical trial included only women. The WAVES and the ARIA study, both in antiretroviral naive women living with HIV. The WAVES demonstrated that elvitegravir covistat TDF plus FTC was superior to atazanavir ritonavir TDF FTC. The ARIA study showed that dolutegravir abacavir 3TC was superior to atazanavir ritonavir TDF FTC. And the WAVE-SOLE study is a switching study in virologically suppressed women from the atazanavir ritonavir TDF FTC. One arm continue with the same regimen, and the other switched to elvitegravir covistat TAF FTC. Similar efficacy was observed in both arms, and also was demonstrated improvement in bone mineral density and renal markers in the TAF arm. In summary, the traditional definition of menopause may need to be reconsidered in this population. It is important to generate awareness among clinicians that menopausal women living with HIV are a group at particular risk of comorbidities, including depressive disorders. Further investigation in some related comorbidities and treatment strategies are needed. Some antiretroviral treatment schemes seem to adjust better than others, and because of the reason mentioned above, women living with HIV is a priority for research. And the barriers are still present: dependency of men, emotional or economically, and of course the competitive priority. Children and grandchildren under their care, family responsibilities over their own welfare. And remember, do not regret growing older. It is a privilege denied to many. I would like to thank my colleagues who helped me with this presentation. Thank you very much. Merci y muchísimas gracias.
So thank you very much. And we are moving now to a question and answer time, and we will stay in this lovely little setting here in the middle of the stage for this. I have a question or two to start out with. If you have questions, please go to the mic and we'll do our best to respond to as many questions as possible. As people are gathering, though, I wanted to ask the panelists a question about funding for women's health, specifically related to the change in policy within the U.S. administration, often called the Mexico City Rule, which is an expanded rule within the U.S. government that says that the U.S. government will no longer fund any organizations that provide any kind of services around abortion or even referrals or advocacy around abortion services, even if those services are done with money that does not come from the U.S. And I was wondering, perhaps Sinead, if you'd be willing to just speak a little bit about the effect you might see of that in access to health, reproductive health for women.
Yeah, so I think that is the implications of the Mexico City policy expansion are something that all organizations that work in reproductive health, I think, are grappling with. And our organization continues to sort of engage with what that means for us. I think for South Africa as a country, though, we're fortunate that we are not dependent on donor funding necessarily for provision of some of these reproductive health services. And our constitution actually promotes choice of termination of pregnancy for women on the basis of research, in fact, that was done over 15 years ago that demonstrated excess loss of life and morbidity associated with incomplete abortions or kind of basically backstreet abortions. So I think that this is a difficult road that we're going to have to tread, but we're more fortunate perhaps than other countries where some of the same provisions are not available for women through the public sector.
Great, thank you very much for that. I also wanted to, I don't know if other panelists may also want to say a few words about that, but I wanted to also ask Isabel if you could say just a few more words about symptoms of menopause and how those are handled.
Okay. You want to make a comment about the policy?
Yes, please do. If you have a comment, please do that as well.
I see that this policy not only affects the abortion, but the family planning in general, and the condoms, provision of condoms, and contraceptive methods. So at the end of the day, we will see more pregnancy that could be avoided with funds, with other policy. And I think that it's a little extortion, because I give you the money to do that I want, that you want, no, I want to do. Not I give you the money so that you do the best that you consider in your place for the women. So I hope that this policy change in the near future as soon as possible. And related to the symptoms, this is a very important issue, Laurel. There are some literature that suggests that the women living with HIV have a greater symptoms related with menopause, especially vasomotor symptoms, hot flashes, and night sweats, and also anxiety, depression. The proposed treatment is hormonal therapy, but we have to pay attention with the hormone to do for severe hot flashes and for short time with the lowest doses, because we have see problems with hormone therapy. Related with no hormone therapy, when we see hot flashes, severe hot flashes with the depression component, it's proposed venlafaxine, escitalopram, and so on, but we don't have enough result to recommend it. With gabapentin, there are seen decrease the hot flashes. And finally, we can find the complementary therapy. Such as isoflavones and acupuncture, but not consistent data. And we have to pay attention with an herb, which is black cohosh, that can decrease the hot flashes, but is associated with liver toxicity. So we have to pay attention, to be careful.
Thank you very much for that. Let me turn to the people at the mics, and perhaps if we could start here, stage right. Please go ahead with your question.
Hi, good morning. Of course, thank you for the presentation. Thank you to the ES who decided to have a special session on women. Unfortunately, even if I think we are more than half of the world population, I'm sure we are not half of the ES registered people in here today. Said this, this means I think that women are not still at least half important. Anyways, not a gender issue now. The question is, first, regarding PrEP for adolescents. We've heard that it wasn't as safe as the rest of population, mainly men who have sex with men, that adolescents maybe because of lack of adherence and this and that. So if there's any further comment. And the second question for Isabel is regarding depression and these mood changes. First, how often should we screen menopause women for depression, and how? Because there's not, should we refer the patient? She won't go to a shrink. I mean, how should we screen mood changes and depression in postmenopause women or non-menopause women? How often and how? Thank you.
Thank you. And I think what we should do is actually take the questions so we make sure we hear them all, and then I'll ask the panelists to respond. So if we move to the middle now, please go ahead.
Thank you. My question's to Sharon Kapambwe, and thank you very much for a fascinating presentation. My name's Constance Mackworth-Young, and I work with young women living with HIV in Zambia at Zambart. And I was wondering if you could comment on how Zambia compares to other countries in the Southern African region in terms of cervical cancer programs, and also why you think what Zambia has done differently to achieve the great successes that you presented.
Great, thank you very much. And if we could take the next comment from the back, and then
My name is Gustavo Lopardo from Buenos Aires. Thank you so much for your conferences. And my question is probably for Dr. Delaney. On Monday's plenary session, Dr. Sheena McCormack, she mentioned that the ring containing dapivirine that was studied through the SPAR study was submitted to the European Medicine Agency for approval. And I would like to know your thoughts regarding which would be the impact of the ring, particularly in the African population.
Great, thank you very much. And if we could take the two questions over here, please go ahead.
Nek Nwokolo from 50 16th Street in London. It was more a comment. We didn't talk very much about hormone replacement therapy, but you did mention the fact that menopausal women with HIV appear to suffer more severely with menopause-type symptoms, including vasomotor symptoms and depression. I would argue that menopausal women who are HIV positive should have access to the same sorts of therapy as HIV negative women, and that includes hormone replacement treatment, which are in fact the treatments for the depression related to the menopause, as well as for vasomotor symptoms. And I think that guidelines are moving away from saying that hormone replacement treatment should be given for the shortest time in the smallest dose, and in fact saying that women who need these hormones should have them for as long as possible. And I think the data shows that if you choose women carefully and correctly, the vast majority of women will benefit from HRT and will not suffer any adverse consequences. Thank you.
And one final question, thank you.
Thank you. I'm Nema Rusibamaila from Tanzania Ministry of Health. And my question goes to the colleague from Zambia. Tanzania, like Zambia, has been able to really expand cervical cancer screening services through using HIV funds. And I just wanted to ask the Zambian colleague in terms of how have they ensured that the screening services are available, equally available to women who are not HIV positive? Because many times the services have been established through support from partners who are focusing on HIV services and focus on the indicator of having, HIV positive women screened. So can you say what percentage of HIV negative women have actually got access to the screening services? Thank you.
Thank you very much. So let's turn to the panel, and would anyone like to go first? Please go ahead, Sharon.
So the first question was, what has Zambia done differently and how are we faring in comparison with other countries in the region? I think as a country we've done tremendously well when it comes to cervical cancer screening for HIV, for women living with HIV, for women who don't know their status, for women who are HIV negative, as I presented. Zambia possibly has the largest cervical cancer screening program that has targeted women living with HIV from inception. And what have we done differently? I think from a high level, in terms of policy, we've seen a lot of government ownership. And the government, the women who are screening are nurses who are employed in government facilities. So they screen as part of their job and not that they are paid by an organization or funding from an organization, but they are on the government payroll. So that has changed a lot. We've had a lot, our first ladies, starting with the former first lady who was a gynecologist, Dr. Kaseba, raised the bar very high in terms of advocacy. When we had the next first lady, the current one, Mrs. Esther Lungu, we still had the same advocacy. So there has been a pass on in the First Lady's office where they have prioritized cervical cancer screening. And this has helped a lot to build the confidence and also seeing that there's a very high political will. When it comes to the question from Tanzania, how many women who are HIV negative are accessing the service? Like I said, initially when we started, the percentage of women who were being screened in our clinics who were living with HIV was 56%. When we did the analysis at 100,000 of women screened, we found that the women living with HIV, without HIV were at 34%, whereas the women living with HIV were 29%. So our clinics are in government clinics, and they are open to all women. What we made sure that we added is to have HIV testing within the screening clinics, because some women come in, there's also a group of unknown status, which I feel that shouldn't be around when we're talking about the 1990. So we still get women who walk into our clinics who are not, who don't know their status. So this is also an opportunity to capture those women, and as soon as we find out their HIV status, there is a system to refer them straight to the antiretroviral clinics. And for the women that we find to have cancer of the cervix, early, late, we ensure that they are started on treatment immediately, and they are referred to the clinic. What happened is that the program initially started through Center for Infectious Disease Research, working in partnership with Zambia, but CIDRS was the one that was responsible with the clinics when we started in the Lusaka province. As we started scaling up the program outside the capital city, we moved into government facilities using government nurses who are on government payroll. They use money from the government grants, from the government money from the treasury to buy their supplies. What happens is that the startup equipment is usually the one that we get the partners to fund. But after that, the clinics run those using the government money. So as we stand now, we still have that partner support, but we know that the clinics are much more sustainable because they are using their own resources from what they get from government.
Thank you very much. A wealth of microphones. Which one would you like to use?
I'll give you another.
Related to the depression screening, the issue is how can I do in our clinical practice to suspect the depression in women? Well, I think that the most important thing is to suspect when there is a loss of in previous enjoyable activities. Loss of previous enjoyable activities. Then is the feeling of guilt, decrease weight or increase weight, insomnia or hypersomnia, and the other thing is the other thing is the lack of self-esteem, feeling so guilt, and we consider all these issues. Is the first step, and then we send these women to a mental health team.
I think there was also a question about how often to screen.
How often to screen? The depression when in each visit. In each visit we ask, how do you feel, or we suspect that the loss of previous enjoyable activities. This is a very important thing.
And I think also taking note of the comment on hormone replacement therapy, and I don't know the challenges and concerns.
I agree with this, doctor. I think that the issue is to try to choose the women. The only thing that I pointed out is to be careful with the interaction between hormone therapy and there is. And yes, the hormonal therapy, as Dr. Vieta said, has been associated with breast cancer, thromboembolism, and other complications. That I think that this is an issue that we have to pay attention to. But I agree with this doctor, and would be beneficial in some particular women.
Thanks very much. Sinead?
Yeah, I think the question about safety of PrEP in adolescents is an important concern for people who are worried about giving drugs essentially to people who are otherwise healthy. The WHO recommendations, which analyze data from the placebo-controlled trials, suggest that the frequency of adverse events is not any greater in those taking PrEP than it was in those receiving placebo, but obviously many of those people were above the age of 18. So there have been some studies looking at data in the 15 to 19-year age group, and in fact Plus Pills has been presented here, and last year data was presented from the ATN, which looked at safety in adolescent populations in the US. So I think the main concerns really are related to renal toxicity and to changes in bone mineral density. And the kind of data to date suggests that those, while there may be changes in about 1 in 200 people, those changes are reversible with stopping therapy. And similarly with changes in bone mineral density. And also they don't seem to be associated with changes in fracture. So I think the thing about adolescence is really that we need to, as we kind of expand access, we need to do more monitoring to reassure ourselves, particularly in the younger age groups, because of concerns about using tenofovir in that population. But I think that, you know, kind of even with our experience to date in our own clinic, we've seen very little evidence of toxicity, but what we hear a lot from adolescents, and some of this, it's often difficult to assess how much of this is also their subjective experience of starting something new and a new medicine when they're not familiar with taking medicines, is that they do talk a lot about nausea and headache associated with startup. And what's very important is to reassure them that this will resolve over time, usually within a month, and that seems to have been the observation that we've had for the majority of people. I think the other question was about kind of the implications of the submission of the ring with the EMEA for sort of regulatory approval. The overall estimates of protection from the intent to treat analysis showed a kind of 30% protection, and it did appear that protection was greater in people who used the ring more consistently. But unfortunately, the one group that was identified as not being consistent users were young people. And so there is a question about whether this technology will be sort of broadly appealing to all of them. There's also work that's been done which suggests that, kind of young people don't have a explicit preference for a ring. But I also think that's about how familiar people are with different technologies. So there are many studies that have articulated preferences for injectables, but injectable contraception is very pervasive in this age group, so it's a relatable technology. I mean, either way, I think it's important that we expand the HIV prevention options that are available, and people, as with contraception, will find a method that works for them at that particular stage in their life. But it's important that we continue to invest in developing new products and also involving end users in their development so that we can be assured of their use of kind of approved products.
Great, thank you very much. I just want to put a challenge. We're out of time, which is, I mean, we're right on time, actually. But what I've been thinking as I'm sitting here is how important it is to bring this information to communities of women living with HIV, and also to the clinicians who are working with us but may not always have access to this information. And so my challenge for all of us is to think about how we take this kind of information further so that women living with HIV in particular and their care providers have it. So having said that, please join me in a round of applause for this really excellent panel. Thank you all very, very much.